Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Dr. Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new TEAM therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. His latest book, Feeling Great, contains powerful new techniques that make rapid recovery possible for many people struggling with depression and anxiety. Dr. Burns is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine.
Yeah.
Okay, we'll stop.
No, I think that's good enough. I think that's good enough.
Yeah. Hello, Rhonda.
Hello, David, and welcome everyone to episode 292. This is the second part of your live Ask David with the Team UK therapists. I'm laughing when we start the podcast because David is either making funny faces or he's doing something else that's funny. And it always makes me wonder what your dinners were like when your family was growing up and how fun they must have been.
I don't know. That might have been a different David, a different era. We'll talk about that stuff one of these days. Yeah, and how I was a member of this paramilitary group when I was growing up.
Oh, yes, that when you were growing up.
Yeah. I had to join it when I was 7 and drill with rifles, and it was very conservative, politically conservative environment.
Well, today you're going to be talking, your first question was from Tom, and he asked you a question of you versus Bessel Van De Kolk. And
yeah, it'll be controversial. I don't know if I'm committing, political suicide or something, but, he makes some really strong and interesting claims. And the British group wanted to know, how that lines up with my trauma experience, because I've treated so many trauma patients, and my experience has been, I would say, a little bit different, to put it mildly, from the way that Dr. Bessel Van De Kolk talks about it. And I'm sure he's a brilliant guy, and he was at Harvard for a period of time, and but I think it's always kind of interesting when you get radically different views about some things. And then there's other good questions that the British people asked as well.
Right. They asked about treating chronic doubters with TEAM, about treating somatic symptoms, about treating generalized anxiety disorder. Yeah.
All great topics.
Well, one thing you have in common with Bessel Van De Kolk is that he is also, he hesitates to use medication.
Oh, that's cool.
Yeah.
I really like that. That's good. Good for him.
Hey, so let's talk about, I could read an endorsement first that is kind of related to this, because we did episode 285 with Derek Riley, who facilitated these questions. And I believe it was because of that podcast with Derek that the Q&A was born.
Oh, yeah.
And we published Derek's episode on March 28th of 2022. And that was about exciting findings regarding using TEAM-CBT for chronic pain. And someone just simply wrote, another fantastic podcast on a very important topic. Kudos to all.
And I think that was our buddy Ed G or something, EDG.
Oh, yeah, you're right.
And he's such a nice guy, and he's so thoughtful. And I always appreciate his comments and, kind. He's an expert, I think, in public health. And so anytime we get an endorsement from him, it's always a tremendous honor. I wanted to mention that I have a podcast, not a podcast, a workshop, a full day Sunday workshop with Dr. Jill Levitt coming up on, what's the day?
May 22.
May 22. That'll be a Sunday from 8:30 a.m. to 4:30 p.m. And it's going to be really
Pacific
cool.
Time.
Yeah, Pacific time. That's California time. California, USA. in case there's another California somewhere.
Right.
And we'll be teaching, not teaching, but treating 2 people live. People we do not know who have been struggling with probably severe depression and anxiety.
If you don't know them, how do they volunteer? How do they get chosen? Could anyone volunteer?
Well, actually, yes, you have to be a mental health professional because I'm not in private practice per se. But yes, and it could be someone listening to this show. If you email me, david@feelinggood.com, we'll take a look, send a partially completed daily mood log describing your problem and your negative thoughts. And then we select a couple people that we think would be suitable for some things aren't suitable for a public, exposure type of thing, you might say. But yeah, we'll be looking for a couple people. So if you have an issue you'd like to work on, make sure you let us know. But the neat thing about this is that it's open to the general public and mental health professionals. And in the past, the Feeling Good Institute has said only for shrinks, and a lot of people have been disappointed. And there's a reason for that, having to do with continuing education and the needs of therapists versus the needs of the general public. But we think this one will be very suitable for therapists and the general public. It's going to be great learning and hopefully exciting, dramatic, and inspirational.
And what I also love about it is that after the demonstration, the participants are going to be divided into small groups, so they'll be able to practice the techniques that you and Jill demonstrated.
Yeah, absolutely. And we'll be keeping the therapists and the general public separated in those small practice groups because the needs of the general public, things you'll need to practice, might be a little different from what the therapists are going to want to practice. But it should be great for everyone. And if it's successful, with this, we might be able to open our doors on a more ongoing basis to members of the general public. We're going to have another killer one on social anxiety in the fall, and I'm pretty sure that one's going to be open to the general public as well.
Cool. Okie doke. So are we ready to listen to the final questions with the UK therapists?
Yes. And I want to thank you, Derek Riley, again, for giving me this chance, and Peter Spurrier and all our wonderful colleagues over in London. We're proud of what you're doing, and we're just excited to be a part of it. And I know you, Rhonda, have also played a big role in the founding and nurturing of the British TEAM-CBT group.
Oh, I want to downplay my role. Thank you. A lot of the people in Team UK have, I met them when I went to England, and we had a meeting together, which Peter Spurrier organized, and they come to the Wednesday training group. So I feel like even though we're, ocean apart, a continent and an ocean apart, that we're friends and we know each other and becoming close.
That's one of the neat things about the COVID pandemic, although there's a lot of horrible things about it, but it's brought a lot of us closer together. And for me, because so many things have gone virtual, my training has become much more exciting for me. I just love the chance to work with Sterling Morey again, to work with people in Ghana, to work with people in London. And you and your Wednesday training group at Stanford are working with therapists from all over the world. If there are therapists who want to join your group, your Wednesday training group, who are listening now, should they contact you?
Well, they should contact Ana Teresa Silva because she's in charge of that for our Wednesday group.
Cool.
And I can tell you her email address is ATERESASILVA SILVA 6@gmail.com. That's Teresa Silva 6@gmail.com.
Right. And if they want to get the information about the upcoming workshop with Jill Levitt, they should go to the Feeling Good Institute website. Is that correct? And
right. If they just go to, yes.
And go to training for therapists, even if you're not a therapist, that's where you'll find this workshop, and you're welcome to come if you're not a therapist. Training for therapists, and then that'll give you all the details there.
Yeah, cool. Okay, here we go.
Okay. Hope you enjoy it, folks.
Okay, David, I'm just going to read out this question because Tom unfortunately can't be here. It's kind of a little bit of an overlap, so it may kind of just be an affirmation of what you were saying before. It's a question about team CBT and trauma. And it says, after reading a book called, quote, The Body Keeps the Score by trauma specialist Dr. Bessel Van De Kolk, it would appear that people with complex treatment require a high degree of stabilizing work, i.e. breathing, meditation, yoga, before they engage in effective therapy. Otherwise, they would neither have the words to describe their emotions, have repressed their memories, and not engage, become destabilized and highly emotional or destructive. The question is, I wonder, is it in your experience with patients that you have seen with severe complex trauma in your career, do you think that Team CBT has limitations in this area? And would you refer to a trauma specialist before embarking on Team CBT?
Well, I can't resonate with anything that you just read, and I'm sure that Bessel Van De Kolk has a great deal to offer and is a very smart individual, but all of that just doesn't map on to any extent in my clinical experience. One of the patients that I treated, I do a lot of volunteer teaching. I'm on the voluntary faculty at Stanford. I'm part of the slave labor faculty, and I started I have this a 2-hour weekly training group, and then and actually we have groups that some of you can join if you're interested. But I started another group for the psychiatric residents and the postdoctoral psychology fellows treating patients live, and I asked the faculty to refer their most difficult cases to this seminar. It was just a 2-hour once-a-week seminar, and I remember one of the women had came because her psychiatrist of 20 years had died, and she was an older woman, retired. She had worked in the high-tech industry and had made important contributions to the cell phone in your pocket right now, and was a lovely woman, but she'd had massive repeated traumas, starting with rape when she was a child, and thing after thing after thing in her life. And she said her psychiatrist was the only person she was close to. And now she'd finally retired, and she wanted to paint. And she was a pretty highly regarded Bay Area painter, and did a lot of the artwork for your cell phone in all likelihood, and things of that nature. But then she had contracted Parkinson's disease. She hadn't told anyone because she was so ashamed, and she had plans to move to Portland because you can get legal suicide there, and was ashamed to tell anyone of her plans, and she was just concerned that no one could understand her or accept her. And so she did, that's a lot of trauma. And yet I just worked with her on how are you feeling right now, and what's going on, what are your emotions, and she had all of these negative thoughts. And one of her thoughts was that nobody could accept her or love her or care about her, and she believed that her entire life. And I can't remember exactly what happened, but I just said in the session, so I think you're thinking no one here could accept you. She says, that's right. And I said, so I imagine that you're thinking that I couldn't accept you. She says, yeah, that's right. You're being nice to me, but you're secretly judging me, just like everyone else, because of this whole issue of suicide that, with the help of a doctor, assisted suicide. No one could accept that. And I said, well, let me tell you about my cat Popcorn, who died in my arms at the vet when he developed terminal, heart failure and lung failure. And I told him, Popcorn, I'm never going to let you suffer. I told him that when he was alive. And when the time came, I brought him with my wife to the vet, and they said, we can put a needle in and pull the water out of his lungs, but it'll just fill up again. And I said, I told her, I said, the time has come, and he could barely breathe, but he was still purring. He was saying, Daddy, I love you. And thank you for the life you gave me. I adopted him when he was 5 weeks old. It was love at first sight. And I loved him every minute of his life. And he just loved me. Even when I took a poop, he would sit on my shoulder, purring. And so they gave him the injection, and he became unconscious. And my wife started sobbing, and she couldn't take it. She walked out into the waiting room, and then after 15 minutes, they said, "Are you ready? Can we take him?" I says, "No, I need to hold him a little longer. I still want to pet him and tell him how much I love him." And tears were going down my cheeks, and I finally gave him up, and they gave us his ashes. But then I told this woman, I said, I loved him, and if we don't want our pets to suffer, why would we want a human to suffer? I said, I absolutely support what you're doing, and I respect you tremendously. And her jaw just dropped, and it just hit her. And then I gave her the homework assignment to start talking to her friends and tell them that she's been ashamed of her Parkinson's, and she's been hiding it, and she can't paint anymore, and that. And ask them how they feel about you. It's just simple, TEAM-CBT, CBT type, experimental technique, survey technique, self-disclosure. And she came back the next week, and her scores had all gone to 0. And she said, if you'd told me that I'd have to be dying of Parkinson's disease after a life of trauma, unable to do the only thing I loved and finally find happiness, I wouldn't have believed you. But that's what happened, and I'm just feeling more joy today than I ever dreamed possible. And that was, presume someone who the top faculty person hadn't been able to help, 20 years of psychiatry, a lifetime of psychotherapy hadn't been able to help. And yet it was just using the same to the empathy. We worked on, her resistance and the assessment of resistance. But I don't like it, I'll be honest with you, people who pretend to know things and talk as experts, especially when what they say doesn't map onto my experience. And I don't know everything either, but I've treated, enormous numbers of trauma patients. And the body knows the score stuff, it just never made sense to me. And I'm a physician. I've worked with a lot of people with pain in their bodies with no organic cause, and use the hidden emotion model to help them recover, even in medical clinics, people who weren't even going for psychiatric help. But at any rate, I just am very optimistic about working with people with trauma.
Thank you, David. That's been really clear, and thank you for that moving anecdote there. So the next question is from Sean. I'll hand you over to Sean.
Hey, David. Thanks very much for taking our questions. I have so many questions. It's like a pick and mix, but I can only ask one. I'm curious, say with the likes of sleep and chronic pain, you just touched on it there. Obviously, it can impact greatly on people's mental health as well. And even if they cognitively can change their thinking, they're still struggling because they may have only had 2 hours sleep or 3 hours sleep, or they're severe chronic pain. So they find it sometimes harder to maintain the changes that they make in session. Sometimes they're just not functioning as well. I'm just wondering what your thoughts are on that, them sort of somatic experiences. And similarly to that, often with anxiety, people maybe will come with the physical symptoms of it. And even though cognitively they can challenge the thoughts, it's still them physical symptoms that they keep coming back with, you know.
Well, those are two different questions and both excellent ones. One, how about people who say they can cognitively challenge their thoughts? And then the other is, and yet they're not being helped. And the other is, how about people with physical pain and perhaps sleep disturbances? What would be the approach to treating them? Did I get that correctly?
Yeah. Thanks.
Well, first of all, on challenging thoughts, cognitive therapy and team therapy have never been about, cognitively challenging thoughts. And I'll also tell you new innovation in cognitive therapy that just came up, a couple of weeks ago. I think it's going to be a major thing. But when people have a negative thought, whatever that negative thought is, a distorted negative thought, like I'm a loser, or my situation is hopeless, or whatever, and they believe that thought, it's generally going to be very disturbing to them. And in order to stop being upset, you need a positive thought. Beck called them rational responses. I don't like that language because many of the people I've worked with have been without a 5th grade education and can't read or write, and they don't like big words. They don't understand big words like automatic thoughts or rational responses. Sounds like a turnoff. But you need a positive thought that has two characteristics. First, it has to be 100% true, or 95% true at least, or it cannot help. Rationalizations and half-truths can't help. Secondly, it has to cause a massive decrease in the belief in the negative thought. And when you see the massive decrease in the belief in the negative thought, that's when you'll see the change in the emotions. So the idea of, well, I can challenge my negative thoughts, well, maybe you can, but you're not doing it effectively. Like if you're still believing the negative thoughts, then in the old days, I used to say you might have to use, I've created over 100 techniques for crushing negative thoughts, distorted thoughts. And in the old days, I used to say it may take 10 or 15 or 20 before you find the one that works for the patient. So you can do a lot of challenging with different techniques and not get a result because the patient still believes the negative thought. Now, in the team era, that has all changed, because if you really reduce the resistance, which is the major reason that people cling to negative thoughts and feelings, then often the first or second or third M equals methods that you try, you'll hit a home run. The new innovation, though, that again has come about because of the app, is I noticed that we had some percentage of the people who have signed up to be beta testers have zero depression at the start of the app. And yet we're asking them to generate a negative thought that they believe. And some of them are coming up with negative thoughts that they believe, but it's obviously not upsetting them. And it just occurred to me that it's a simplistic thing, but it had kind of eluded me, that to upset a person, you not only have to have a negative thought, but it has to be upsetting to you. And so because you could have a negative thought well, the time is almost up for this seminar. That would be a negative thought. I'd feel sad about it, but I wouldn't be feeling worthless or something. You see what I mean? Or it's raining today. That might be a negative thought, but it might not make you feel inadequate or depressed or panicky or something like that. So the thought has to be upsetting to you. So there's two dimensions I'm now thinking in assessing negative thoughts. The belief, which is terribly important, because if you have a negative thought you don't believe, it can't possibly upset you. But secondly, the valence of the thought, or the upsettingness of the thought. How upsetting is this thought to you? So so I'm excited about that, and we're starting to measure that in the app too. And I'll be modeling this mathematically too, to see the relative contributions of these two dimensions, and if that might be opening things up in some new ways. Now, as far as pain, physical pain, when I was running the groups in the Stanford inpatient unit, again, as part of my volunteer work, they had I created an hour-and-a-half daily cognitive therapy group, because they had no psychotherapy, just electroshock therapy and medications for the most part. And they had a pain unit connected with the psychiatric inpatient unit. And so we had pain patients, PAIN, pain patients, along with the other psychiatric patients. And so I did a study of, and I developed a 2-item pain scale that has a 98% reliability and can be completed in 10 seconds, and has high correlations with the research scales on pain, the McGill, I think there's a McGill scale and others. So I did a study on changes in pain from the start to the end of the cognitive therapy group. How much reduction in pain could we see in an hour-and-a-half in these patients with chronic pain? And I was also studying their brief mood scale scores at the start and end of the cognitive therapy session. So we had changes in depression and anxiety and anger, and changes in physical pain. And then I was able to do a structural equation model to say, why are measures of pain and depression correlated? Does negative feelings, do negative feelings cause depression and anger, or do feelings of depression and anger cause pain or magnify pain? And or are both true simultaneously? And what the data showed overwhelmingly was that there was a massive causal effect of all negative emotions on pain, physical pain. And it has a magnifying effect. And so that when someone is complaining of pain, and this is true of organic pain, like from a broken bone or arthritis, or pain that has no physical illness causing it, it's the same exact result. Half of pain on average is the result of the negative feelings the person has. The pain does not have large contributions to the depression, to the anger, to the anxiety. The main causal direction is in the opposite direction. And what that means is, and what we saw is that some of the patients with chronic pain, if they were willing to work on their feelings and get that aha change in that hour-and-a-half group, some of them, their pain disappeared completely after often decades of failed therapy. Others, the pain went down an average of 50%, and others had no improvement. So on average, 50% of the pain people feel comes from the negative emotions that they're having. And when you reduce or eliminate those negative emotions, you can see on average a 50% increase in pain, meaning some patients will go all the way, the pain will disappear. Some patients will be helped not at all, and some will be helped, like halfway. And then I've replicated that in 2 other large databases where I had access to measures of depression and pain, like in a group of 1,000 patients from the University of California Medical Center in San Francisco, arthritis patients who had severe depression and severe physical pain, and then, all levels in between. And then I did the same mathematical model there and got exactly the same parameters, that on average, half of physical pain results from emotional factors. And so there's a lot you can do just by focusing on the problems in the patient's life and the negative emotions. If they're willing to work on those things, then many of them, but not all, will be helped quite substantially by the psychotherapy. But some patients with chronic pain will not be helped through this type of mechanism, and perhaps do not want to be helped. Are not eager for a psychological explanation of their pain or a psychological treatment.
That was very helpful, David. I just want to say I had a moment of enlightenment myself when you talked about that. It's what I realized is with pain or sleep or even depression, anxiety, it's not necessarily any of those things. It's what I picked up from you is your thoughts about them actually tend to be worse. And it's the pain itself you can bear, or the sleeplessness you will bear, or even depression, anxiety. You'd often hear that in spiritual literature, just let it be and it'll probably pass, but it's the thoughts about it that makes it, as you say, twice as bad or 10 times as bad. So that's been very helpful for me. Thank you.
Yeah. I had a personal experience that demonstrated that effect of emotions on pain, because when I was a medical student, we used to go to this bar in Palo Alto and, kind of have a few beers, and a fight broke out one night, and I wasn't involved in the fight, but I heard the commotion, and then I turned my head and I saw this beer mug coming toward my face in slow motion, stop action photography, and it hit my jaw and exploded on my jaw, and blood came gushing out of my mouth, and I realized my teeth were loose and that my jaw was broken. And I was panicked and ran out of the bar and got in my old Volkswagen and drove about a mile to the Stanford emergency room and went in. I said, I think my jaw is broken. And I was high and angry, and I had the idea, I was probably a very obnoxious patient, that somehow I wasn't being treated properly, and I was panicky, and I was worried about losing my teeth, and the pain was just excruciating. And they finally got a plastic surgeon or something like that in to see me. And he said, I've looked at your x-rays, David, and you have a broken jaw, and we're going to put you in the hospital, and I'm going to do surgery on you in the morning, and I'm going to wire your jaw shut, and then it'll be shut for about eight weeks. And then they'll remove the wires. And I said, well, do you think I'm going to lose my teeth? And he said, well, several of your teeth are pretty loose, but we'll send you to an orthodontist after we get the wires out of your mouth. But I think you're going to be able to save all your teeth. And to tell you the truth, the break in your jaw, it's a pretty ordinary thing, and we're gonna fix you up tonight. And don't worry about anything. And he touched my shoulder, and then he said, I've ordered really powerful shots for you tonight of, strong painkillers. I know you're in excruciating pain, and you can have as many shots as you want. I just want you to be super comfortable tonight. But the odd thing was that the moment he touched my shoulder and said everything's going to be okay, my pain totally disappeared. My anger suddenly disappeared. My panic suddenly disappeared. And poof, the pain went out the window. But this was clearly organic pain. This wasn't some psychosomatic pain. And that impressed me, the massive impact of negative feelings on physical pain.
Thank you, David, for that. Just moving on, we've got quite a few questions to try and squeeze in. So the next one is from Hassan.
Hi, David.
Hi.
Thank you for doing this. I just wanted to get your take on treating people with chronic doubting, like really sticky doubting, who just get stuck on what ifs, right? What if all of this cognitive therapy that we've done is, just a gimmick, I know that we've crushed our negative thoughts and everything, but what if we miss something? What if I really am worthless? And that really sticky what if that some people have, that they can't seem to get to any certainty. And I know that's kind of a problem in therapy for me.
That's a cool question. I've just wrote a document I'm thinking of attaching to one of our upcoming podcasts, because the question is, how do you teach acceptance? And so I've written a document called 20 Paths to Acceptance, and 20 different techniques you can use to help people learn the concept of acceptance. And then one of my students said, well, you need number 21, uncertainty acceptance. For these chronic doubters. I haven't written that up yet. I was just starting to think about it. But in general, people like this will be very anxious, and they're probably having a form of obsessive compulsive disorder where they're doubting everything. And I can say that I use 4 treatment models always in working with any anxiety disorder. The outcome and process resistance issues, that's the motivational model. And to get them to see, how unwise it would be to give up this doubting and what it shows about them that's positive and awesome. You do a daily mood log, and you've got all these emotions and all these thoughts, and to really challenge them on maybe that isn't something you'd want to be giving up. So you've got to find out first if they're on board, and they see all, and you can use externalization of resistance, all the really good reasons not to give up that doubting and all the awful things that might happen if you do. So the first thing is to deal with the outcome and process resistance. And the process resistance too with anxiety has to do with, would you be willing to use exposure techniques even if they were terrifying to you and profoundly upsetting? So that's one of the 4 models. That's the motivational model, and every patient, that's got to come first. After the empathy. See, are they really on board with getting over this? Then, secondly, of course, would be the exposure model. If they are willing to do exposure, you can do the what if technique. What are you the most afraid of? What's the worst that could happen? And see if they can do cognitive flooding or flooding in reality, depending on what they're afraid of, and make themselves incredibly anxious, and then endure that for as long as possible, not fighting against the anxiety, but fighting to make the anxiety as bad as possible until it disappears, and they can no longer forcefully make themselves anxious. The third model would be the cognitive model. People say that cognitive therapy has no value for anxiety or OCD, and that's the kind of ridiculous things that people say because they want to hear themselves talk. And one of my colleagues did a study comparing exposure for OCD with cognitive therapy and no exposure for OCD, and got exactly the same results in both groups. I think the use of the Dailly Mood Log, what's the thought you want to challenge, put it in a recovery circle, select 10 or 15 techniques for crushing that thought, do externalization of voices. That's very helpful. And then the thing that everyone overlooks is this amazing hidden emotion technique. A high percentage of these people have something in their life in the here and now that they're not telling you about that's upsetting to them. And until that comes to conscious awareness and they deal with it, the most you can hope for is maybe a 50% improvement. You can't expect a complete cure. And that's a really beautiful model. I could tell you more about it now or on some other occasion, but that's crucial. And I've had so many anxious patients. I was kind of stuck halfway through the treatment, and they improved, but they were still symptomatic. And then I came to the hidden emotion model, and eureka, we suddenly hit the ball out of the park. And I could explain that model now or on some other occasion. But that's how I proceed with all anxiety disorders. And I never try to treat anxiety with one approach. I always say that exposure and response prevention are not a treatment for any form of anxiety. And then people get pissed off because Edna Foa, a colleague from Philadelphia, has done amazing research showing that exposure and response prevention have many powerful effects for OCD and other forms of anxiety as well. Well, my statement is it's not a treatment. It's a tool in a treatment package. But I come in with all guns blazing, using many different models because they can help the patient from different perspectives and in different ways.
Thanks, David. That's really cool. Thank you.
You're welcome.
Thank you, David. We've probably got time for one more question, and that's going to be go with Tim. I'll hand over to Tim.
Hi, Tim.
Hello, David. Sorry, I was muted. I was so entranced by listening to your words that I was still on mute. Thank you so much for being here. A quick question, and it's sort of kind of jumping straight to methods, really. I'm kind of ignoring T, E, and A for a second, and you'll probably chastise me for that. But just some guidance, really, for a client that has really got a downer on themselves. They think they're not good enough. And when you're trying to examine the evidence, the client can only come up with evidence as to why they're not good enough. You know, maybe a parent didn't give them the love and support they wanted, the husband beats or mistreats them, they have no close friendship. So I guess I'm looking at an example where somebody can only find evidence that actually supports that kind of negative situation. And I just wondered how you might sort of traverse that sort of situation.
We'll have two questions for the group right now. How many of you sometimes struggle with the idea that have the thought, I'm not good enough for yourself? How many of you sometimes feel like you're not? So that's one that we all experience. And then the second question is, when a technique doesn't work, we got this thought, I'm not good enough, and we have a recovery circle with a minimum of 18 techniques we could use to crush that thought. So what do you do when a technique doesn't work, folks?
Use another one.
Yeah, go on to the next technique on your recovery circle. Don't waste time on it. That's why I developed all these techniques, because when I learned, examine the evidence was one of the few techniques Beck had, and his other techniques were pretty dry also. And they occasionally help, but they often didn't. So I said, let's try more techniques. So that's one answer. Don't be surprised. Examine the evidence is a nice thing that's occasionally helpful for some people, but I wouldn't go overboard on that or any single technique. And there's so many other ways to crush that thought. And then the other thing to think about is what you said yourself. The most common cause of therapeutic failure is what? In fact, the Buddha said this 2,500 years ago. He said 99% of therapeutic failure is due to what? What is it? What causes therapeutic failure?
Trying to help.
What is it?
Trying to help.
Well, yes, trying to help and not dealing with therapeutic resistance and the assessment of resistance. And that's why you want to go into the assessment of resistance, because this thought, I'm not good enough, shows at least 15, that thought alone, 15 completely different, fantastic, wonderful things about that person. And so the first question is this a thought that they're ready and willing to crush? And what do all these negative thoughts and feelings show about them that's positive and awesome? I mean, I'm not good enough. Well, gosh, that shows that you have high standards, right? And it shows that you're honest because about your shortcomings and failures. That's a beautiful thing. It shows that you're a person of humility. How great is that? Humility is a spiritual quality. It shows I'm not good enough. It shows that you're accountable rather than, blaming fate or blaming the world, and on and on and on. And so you really need to develop that dimension and have the patient see why, in fact, they really do not want to let go of that thought, because they won't be able to let go of it until you've sold them on not letting go of it, and until they see how awesome that and powerful that whole resistance thing is, and that they're resisting not because they want to feel sorry for themselves or because they're trying to get attention, but they resist because that thought is the expression of things about them that are positive and beautiful and awesome and their core values. They're resisting because it helps them. That thought helps them in many ways. And often they're resisting because the thought is totally appropriate and healthy, and the thoughts and the feelings given their circumstances. And so that's where you really, really want to go. And one of my students in the Tuesday groups working with perfectionistic high school students in Silicon Valley. And of course, man, there's tons of them, high achieving perfectionists. And she says, sometimes the techniques don't work. And I says, well, I bet you're not dealing with their resistance. And I taught her how to do externalization of resistance, how to come up with all the reasons not to give up their self-critical perfectionistic thoughts. And I said, I wouldn't work with anyone until they could hit all these forms of resistance out of the park. You can do externalization of resistance, like externalization of voices. And then the next week, she said it was just had transformed her clinical practice. So, I mean, that's a great question that you asked. And it's really the key to all depression, because all depression results from I'm not good enough. So
that's
thank
great.
you, Tim.
Yeah, thank you, David. Brilliant. Thank you.
Thank you, David. I'm conscious of the time. There's only about 3 or 4 minutes left, so we could try and squeeze another question in. Do you want to try?
It's always fun to do that, yeah.
Okay. And the next question is from Jackie, if she's around.
Hello, David. Thanks so much for joining us in the UK. We're all super excited to have you here. My question, please, is if clients present with multiple worries on multiple topics, do we need to restructure every worry, or do we look at worry as a process in and of itself?
Well, I don't do either of those things.
Okay.
And that's why I like the fractal concept of TEAM-CBT. All her suffering or his suffering will be embodied in any one moment when that person is worrying or upset. And so I get a daily mood log focusing on one example of that to see what kind of things they're telling themselves and all the feelings that are associated, what type of upsetting event triggers that type of worrying. Then in general, I would be using all 4 models that I mentioned previously, the motivational model, the exposure model, the cognitive model, and the hidden emotion model. And once the person has knocked it out of the park at one moment, then whatever techniques were helpful to them at that moment, it'll be the exact same thing with all the moments when they're worrying. I treated a woman who had 58 years of failed therapy for chronic worrying, and she came to our clinic in Philadelphia. And I'll make a long story short. It turned out that the hidden emotion model was the thing that worked for her. And it worked. Really, I saw her for an hour one evening, and then an hour the next morning. She came up from Florida for an intensive. And by the end of the next morning, she was cured, and her worry had finally disappeared for the first time in 58 years. But it was just that she was often worrying that her sons were going to get killed when hiking, and that her husband would have a heart attack and suddenly die. That was what and then it just turned out she was pissed off at them. But she'd been taught, you should never be angry if you love somebody. And once that came out, and I gave her some little help on expressing her feelings to her sons and her husband, she did beautifully. And suddenly she wasn't worrying anymore. And then I just told her, now the good news is you're permanently and irreversibly cured of worrying after 58 years of failed therapy. And it didn't take you long either. And the even better news is you're going to keep worrying for the rest of your life. And I said to her, why is that the even better news? I thought you said I was cured. And I says, yeah, sure, you're cured for now, but you're going to start worrying again. And why is it great that happened? She said, oh, because I'm upset with somebody again? I said, exactly. And so whenever you start worrying, it means there's something you're not attending to in your life, and you need to tune into it and deal with it. And then lo and behold, your worries will disappear again. So that, and now another thing could be the key for another person, but that hidden emotion thing was what did it for her.
That's such a lovely, uplifting story to hear
Thank
about.
You.
I love that image of her.
It's lovely to be able to help people quickly. It makes us feel good, and that's why we went into the field.
It's so meaningful. Thank you so much.
Yeah.
Thank you, David. We've come to the end. It's flown, hasn't it, an hour and a half. And I just want to say what an honour and what a fantastic experience. I've made loads of notes myself. So thank you very much for sharing all your clinical wisdom. Unfortunately, there are people that have asked questions that haven't been answered. So I wonder if I may be so bold as to ask you to come back another day sometime, David.
Sure. I'd be happy to do that. Absolutely.
Fantastic.
It's real easy for me just to take an hour in the morning and an hour and a half, whatever, and schmooze with you folks. So it's fun.
Thank you.
Fun for me.
Thank you so much for those. So I'm sure we'll have plenty more questions filled. So that gives everyone an opportunity. And those that haven't answered a question, or have had a question that haven't had a chance to pose it, they will be first next time. So thank you very much. And thank you, David. It's been an honour. And thanks for sharing your time with us.
Thanks, everybody. I love you all, and it's just great fun for me.
Okay.
Okay.
Take care, everyone. Bye, David.
David.
Bye.
Bye.
Thank you.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. I am your host, Rhonda Borowski, the director of the Feeling Great Therapy Center. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.